Hello, everyone. Good evening, and welcome to the first week of Advanced Evaluation and Management Group Study Session by AMCI. Good evening, coders, and I do see a lot of familiar names in the chat. Yes, we all met in the part three in the two-stage study groups, and we are back to the with the evaluation and management class as well. Hello everyone. Good evening, good evening, good evening. So yes, I know that you all have been waiting for these advanced E&M management group study sessions. It is going to be similar how we done the Tuesday group study sessions as well. So let's not waste much time and let me introduce to my team, the interns. They are the backbone of these group study sessions. So let me introduce Ms. Zanya, Miss Karen, Miss Sandra, and Miss Stephanie. So we also have our AMCI curriculum director, Mrs. J, with us, and that's me. I'm going to be your instructor for these group studies. So let me quickly look into chat. How are you all doing? I can see everyone saying hello, good evening. All are doing good. Yes. Okay, coders. So what are we going to do in this advanced E&M group studies? We'll be reviewing some of the office visit guidelines. So it's a little bit different from how we highlight for the Tuesday group studies. In E&M advanced group studies, the things which we highlight, the keywords that we highlight is going to be the age of the patient, the diagnosis, which are the signs and symptoms, the exam, the procedures, anything which the doctor does, the total time, the medical decision making, which is MDM, and finally the data is reviewed. So how to select the E&M code? Yes. Answer or do the following. These are a few set of questions which we answer before arriving to the correct answer, or before picking the correct E&M code. We would ask ourselves whether there is a medically appropriate history or exam performed, the location of the visit, whether it's an office visit, inpatient hospital admission, emergency department admission, whatever maybe, we will check for that. And third, type of the visit, we will check whether it's a new patient or an established patient. We will also check the total time of the visit, medical decision making. So if the total time is not documented, we are going to inventory the MDM and then score, and then select the ENM code from the evaluation management table. And finally, we will apply all the guideline. How to select an ENM code when the time is not documented? In those scenarios, the questions will remain the same except the one question, whether there's a medically appropriate history or exam, the location of the visit, the type of the visit, whether it's a new patient or an established patient, the medical decision making. Then we would inventory them and then score. Yes, we are going to review how to score the MDM portion. For that, we use the PDR chart, which we will come on the talk about on the coming slide. And step 5, ENM tables to select the code, and finally apply all the guideline. How to select an ENM code based upon time, based upon the total time. Once again, questions remain the same except one particular question. Would ask whether there's a history or exam. Would ask about the location of the visit, the type of the visit, new or established patient. Then step 4 would be a total time of the visit. And step 5, which is MDM, that won't be there if you are going to select the ENM code based on time. Step 6 would be ENM tables to select the code, apply all the guidelines. So as I said, step 5 won't be there if we are using total time to select the ENM code. Yes, so we were talking about MDM table, and how to select the MDM code, how to inventory them. For that we use our PDR chart. Yes, review and score the documentation for the MDM. So since we know that the MDMs are evaluated and scored based on these three categories, so I will be referring them, these three items, as PDR. So just so you know that this is the new PDR chart is available in your MCG manual. So what is PDR standing for? P is for problems. Yes, it is for number of problems and complexity of the presented problems. And D stands for data, the amount or complexity of the data that has been reviewed by the doctor. And R stands for the overall risk. Yes, R stands for risk, and that's our PDR chart. And we have a new PDR chart with us. So it's available in the MCG manual, as I said. So we have added the codes for the hospital observation, the consultations, outpatient, nursing visits, home visits. So it's a new PDR chart that's available for you all. So once again, the PDR chart is found in your MCG manual. And that's what we are going to use in our study sessions here to solve the questions. So as we said in the beginning, this is an advanced ENM session. So I presume that you should be already knowing the coding for the office visits, how to score an MDM, the coding for hospital and observations, coding for the nursing visits, coding for the prolonged services, and for the ED visits as well. So coders, the class today is going to be from 7 p.m. to 9 p.m. I see there's a small changes that need to be made in the heading of the invitation for the group study. So it's going to be 2 hour group study session. So let's move on. Yes, let's move on to the topic. Let's move on to the topic. So we would be reviewing the home visits. So what's an home visit? Let's review the home visit guidelines first. Yes, what's an home visit, a home or a residence visit? So CPD has defined home as a private residence, temporary lodging, or short-term accommodation. It can be a hotel, campgrounds, hostel, or cruise ships. So these codes are used when the resident is an assisted living facility group or a group home that is not licensed as an intermediate care facility for individual with intellectual disability. So that is very important. So group home that is not licensed as an intermediate care facility for individual with intellectual disabilities, custodial care facilities, or residential substance abuse treatment facility. So as I said, these are coded for assisted living, group homes, custodial care, residential substance abuse treatment, intermediate care facility for individual with intellectual disabilities, and services provided in psychiatry, residential treatment centers, and nursing facilities. So when using time, do not count the travel time. So that's all about the guideline for home visits. So let's move on to the first scenario of the day. So coders, are you ready? Are you ready to take it? Are you ready to the challenge? Yes, you all are. And let me invite, I think it's going to be Miss Stephanie to read the first scenario for us. Miss Stephanie, please, and thank you.
Thank you, Mr. Sandeep. Hello, coders. So glad to have you here. Welcome, welcome. What CPT code should be used for this home visit? A 75-year-old patient, Mr. Johnson, is visited at his home by his PCP, Dr. Smith, due to mobility issues. Dr. Smith performs a comprehensive examination, identifies and manages the patient's DM, COPD, and chronic pain, and provides medication management for his illnesses. Oh, I'm so sorry. The CPT codes that should be used for this home visit is A99334, B99349, C99350, and D99341. You have 2 minutes to solve, and your time begins now.
So that is time and coders. How are you all doing? Let me quickly look into the chat. Yes, great way to start the E&M session, coders. I see amazing answers in the chat. Great answers in the chat. So let's solve this scenario. So thank you, Miss Stephanie, for reading the first scenario for us. And let's start highlighting the keywords, coders. We have Mr. Johnson visited at his home by the PCP. Doctor performs a comprehensive examination, manages patient's DM, which is diabetes mellitus, COPD, and chronic pain, and provides medication management for his illness. So, what is the CPT used for this home visit? Answer is going to be option B. Yes. So, this is how we start eliminating eliminating the wrong answer, let's look into option A, which is for 99334. And if you go and search for the code 99334, I think we will find as it's, yes, over here. It is a deleted code. Yes, if you look under domiciliary, rest home, or custodial service category, care service category, you can see that 99334, 99335, 99336, and 99337 has been deleted, and it guides us for domiciliary, rest home, or custodial care services. Established patient, see the home or resident service code 99347 to 99350. So with that, I can be sure that option A is incorrect. Now, let's also look at option D, which is coding for 99341. That is for a home or residence visit for evaluation and management of a new patient. So, coders, is this a new patient or not? Is Mr. Johnson new patient? Yes, he is not a new patient. He is not a new patient to Dr. Smith. Yes. Why? Because it's not documented. So as long as it's not documented as a new patient, we are going to take them as established patients. So option D is also incorrect, and that leaves us with option B and option C. So before going to option B and C, let's answer these questions. Is there a medically appropriate history or exam performed in our scenario? So my answer is going to be yes. And location of the visit coders. Exactly, it's going to be a home visit. Type of the visit, or whether it's a new or established, we already said that's an established patient. Now, total time documentation, there is no total time documentation. So, what are we going to do next? We are going to inventory the MDM. Yes, we have to use the MDM. So, we're going to inventory the MDM and then score. So yes, these are our inventories. We are having problem address, we have diabetes mellitus, COPD, and chronic pain address in the scenario. So next question, what did the doctor do or is going to do? There is a medication management. Yes, there is a medication management which is performed. So next we are going to pull out our PDR chart, and let's see where does these falls in our PDR chart. So where does it falls in a problem chart, where there's a chronic problem such as TM, COPD, chronic pain falls, Codus? This is the question for you. I see only one answer in the chat. Let's make this one interactive, Codus. Let's make these study sessions interactive. Where can I place these problems in PDR chart? There you go. Now the answers are coming. Yes, so in the problem column, yes, I would take it under moderate problem. Why? I would take it under two or more stable chronic illness. Yes, we are having a diabetes mellitus, we are having COPD, we're having chronic pain. So we can take it as a two or more chronic problem. Yeah, so it falls in moderate problem level 4. How about the data? How about the data goddess? Where does it falls? Yes, there is no data that has been reviewed in the scenario. So no data means minimal or no data. It falls under straightforward data. Yes, it's a straightforward level 2 data. And next, coming to the risk, where does it falls? There you go. Risk, it falls in moderate because there's a prescription management which has been performed, right? There's a medication management that is performed. So it falls in moderate risk. Exactly. So, what do we have here? We have a moderate problem, we have a straightforward data, and we have a moderate risk. So, what is our ENM level going to be? Coders will throw the lowest level out and select the next. So, our ENM is going to be, yes, ENM code is going to be 99349. Yes. And there you go. The code is already in the PDR chart. Yes, that's why I said in the beginning we have got a new PDR chart where all the codes has been already mentioned in the final code description. So we are having yes 99349 for an established home visit. Yes, I love the comments in the chat. Exactly. Everyone is participating, and that is how it should be in group studies. Great work, coders, on the first scenario. Yes, so the correct answer is option B, 99349. So let us know how are you feeling, coders? How are you feeling after the first session? Yes, great. So let's move on. Let's move on to the next challenge. Let's see what we are having here. Okay. So next we are going to review the rest home doctor visit, which is also coded as home visits. So traditionally, a rest home is a type of long-term facility that provides a home-like setting for the seniors who require assistance with daily activities such as bathing, dressing, and medication management. So the residents in the rest home generally do not require skilled nursing care, but may need the help with some of the activities of daily living, or may have some medical condition that requires monitoring. Now, on the other hand, we have nursing home, which is also known as skilled nursing facilities. The provider provides which provides a higher level of care and supervision. Yes, it will a nursing home or skilled nursing facility provides a higher level of medical care for the seniors who requires 24 hours of nursing care and supervision due to complex medical conditions, chronic illness, or disabilities. So the nursing homes provide medical treatment, rehabilitation, and skilled nursing care that is typically not available in rest home. So that's the difference between the skilled nursing facility and rest home. So in short, the main difference between the rest home and the skilled nursing facility is the level of medical care and supervision that has been provided. And the rest homes are designed to provide basic assistance with daily activities and socialization, while nursing home provides skilled nursing care and rehabilitation services. So, however, it is worth noting that the definition and regulations surrounding these terms may vary by region or by country. We also have a domiciliary rest home, which is a type of long term care facility that provides residential care for the seniors who require assistance with daily activities but do not require the level of medical care provided in a nursing home. So, domiciliary rest homes may be also known as a residential care homes or assisted living facility. They are typically designed to provide a home like environment where the residents can receive assistance with personal care, medication management, and other activities of daily living while maintaining their independence and dignity. So, the residents in the domiciliary rest home usually have their own private rooms or apartments and uh, receive their meals, housekeepings, and laundry services. Some of the facility may also offer recreational activities, transportation, and other services to support the residents' well-being. So that is the differences between a domiciliary rest home, a skilled nursing facility, and a normal rest home. So said that, let's move on and let's code for some of the scenarios under rest home. So once again, I would invite Let me see who's coming up next. I think it's Miss Karen who's coming up next. Miss Karen, please and thank you. I'm sorry. I think it's Miss Stephanie itself who's going to read the second sentence. Sorry, Miss Karen.
Yes, and thank you, Mr. Cindy. Coders, again, welcome. What CPT codes should be used for Dr. Thompson's visit to the domiciliary rest home? A 99341, B 99308, C 99309, D 99347. An 82-year-old patient, Ms. Brown, resides in a domiciliary rest home due to her age and physical limitations. Dr. Thompson, her PCP, visits the rest home to assess her overall health, provide necessary care, and evaluate her medication management. During the visit, Dr. Thompson carries out a medically appropriate exam and spends a total of 25 minutes during the encounter. The C your this, again, what CPT codes should be used for Dr. Thompson's visit to the domiciliary rest home? Your time begins now. Good luck.
And that is the time. And once again, thank you, Miss Stephanie, for reading first two scenarios for us. And let me look the chat. Okay, Gordon. So let's solve this one together. Let's highlight the keywords. Age of the patient, 82-year-old, resides in domiciliary rest home. Dr. Thompson, her PCP, visit the rest home. Medically appropriate exam has been carried out, and doctor spends a total of 25 minutes. What is what are we coding for? We are coding for Dr. Thompson's visit to the domiciliary rest home. So the correct answer, yes, as most of you have said, correct answer is going to be option D. And this is how we eliminated the wrong answers for this scenario. Looking to option B and option C, which is coding for a subsequent nursing facility care per day codes. So is this a skilled nursing facility care or a first necessarily a nursing facility care services provided in our scenario? No, it is a it's we are coding for Dr. Thompson's visit to the domiciliary rest home, not to the skilled nursing care, or we are not coding for a nursing care services here. So option C, B, and C is straight away it's incorrect. And looking to the rest remaining options, option A and D. A is coding for a 99341, which is for home or residence visit a new patient. So is this a new patient coders? No, it's not mentioned as a new patient. And this is an established patient visit. So option A is incorrect as well. And the correct answer is going to be option D, which is for a home or residence visit for evaluation and management for established patient, which requires medically appropriate history, examination, straightforward medical decision making. And what's the total time spent here? It's a 25 minutes, and these codes are used when the total time on the date of encounter for the code selection is 20 minutes or more. So yes, the correct answer for this is option D, 99347. So I see most of you have done pretty good with this one, and now it's time for us to move on to the next scenario. Yes, the third scenario, and this time Miss Karen is coming up and read the scenario for us.
Thank you again. What CPT codes should be used for Dr. Lopez visit to the domiciliary rest home? A 99309, B 99214, C 99342, and D 99348. A 90-year-old patient, Mr. Taylor, resigned in a domiciliary rest home due to age-related frailty and limited mobility. Dr. Lopez visited the rest home for the first time to perform a routine health assessment, monitor Mr. Taylor's chronic condition, and review his medication regime. Dr. Lopez spent a total of 30 minutes evaluating Mr. Wilson during this visit. Huh. What CPT should be used for Dr. Lopez's visit to the domiciliary rest home? You have 2.5 minutes. Be forensic.
So I can see everyone answer in the chat, and I think Miss Karen, they are super forensic. They all are rocking in the chat. So yes, coders, great answers. So let's highlight the keywords here. 90-year-old patient, domiciliary rest home. Dr. Lopez visits the rest home for the first time. Total time is 30 minutes spent. And what are we coding for? We are coding for domiciliary rest home. So the correct answer, as most of you have said, is option C. So again, what are we coding here for? We are coding for a domiciliary rest home services which is provided by Dr. Lopez. Looking into option A, that is for 99309, subsequent nursing facility care. No, we are not coding for a nursing care facility care services. 99214, that is coding for an office or outpatient visit. Again, it is not what we are looking here. We are looking for the services provided for the domiciliary rest home visit. And 99342, before that, let's look option D, 99348, that's for home or residence visit. Established patient. So is that an established patient, Goddess? You all are forensic. The patient has been seen for the first time. Yes, that's been documented here. The patient has been seen for the first time. So option D is also wrong. And the correct answer is going to be option C, 99342, which is for home or residence visit for evaluation and management of new patient, which requires medically appropriate history. This is a medically appropriate history, examination, and low level MDM. And the total time spent is 30 minutes. So these are used when total time on the date of encounter for code selection is 30 minutes or more. So option C, 99342, is our correct answer. So well done, coders. You guys are nailing the home visit. So I think you don't need any more challenges in home visit coding. So thank you, Miss Karen, for reading the third scenario for us. And let's move on this time. So we are moving away from the home visit, and let's see what are critical care and what is a critical care guideline. So critical care is one of the important, I would say important portion in an E&M series, because they have few guidelines to them. So let's review some of these guidelines. The 992, 91, 992, 92 are used for the time spent for treating critical illness acutely impairs one or more vital organs. So we'll be discussing what critical illness are. So now from the 29 days to 71 months in inpatient infant critical care services given, we have to refer for the code series from 99471 to 99476. For the 28 days or younger inpatient infants critical care given, you have to go for 99468 and 99469. Outpatient all infant critical care services given, the code series is 99291 and 99292. If inpatient and outpatient critical care service code for the inpatient critical care services, the critical care services may be reported with other E&M service. For critical care in ED, see ED guidelines. Use 99291 and 99292 for critical care attendance during the transport services for critically ill or critically injured pediatric patients 24 months of age or younger. See the code 99466, 99467. So these are only few guidelines which I've churned here. So coders, please go ahead and do your churning for critical care services, because they have a lot of guidelines, and get them covered before the exam. So these are the example of critical illness which we were mentioning before. So these are few of critical illness for which critical care services are given. They include the central nervous system failure, circulatory system failure, shock, acute renal failure, acute hepatic failure, acute metabolic failure, and respiratory failures. So these are few of critical illness. And now let me introduce you all to the table which we would mostly use to solve the critical care service scenarios. And these tables are very, very helpful. So when a total critical care service is a time is being given, which is critical care service given is less than 30 minutes, we are not going to assign any critical care codes. We're going to give appropriate ENM codes for them. And when the total critical care has been given for a time between 30 to 74 minutes, that is 1 hour 14 minutes, the critical care code is going to be 99291 times 1. When the total critical care service, which is given between ranges between 75 minutes to 104 minutes, which is 1 hour 15 minutes to 1 hour 44 minutes, the critical care service CPT code is going to be 99291 times 1, 99292 times 1. And when the critical care total critical care service which is given is between 105 to 134 minutes, we would assign the critical care codes 99291 times 1, 99292 times 2, and the add-on code keeps on increasing its units in 30 minutes interval. So that is how we code for critical care evaluation and management services. So please don't hesitate to look these charts to solve critical care codes, because that makes life easy. That makes life easy for me, the tables. Okay, now let's move on to the first critical care scenario of the day. And once again, I would like to invite Miss Karen to read the code for us, this scenario for us.
Okay, guys. What CPT code should be used for the critical care service provided to Mrs. Adams in the outpatient clinic? A 99285, B 99291, C 99292, and D 99284. A 60-year-old patient, Mrs. Adams, is brought to the ED after experiencing severe chest pains, shortage of breath, psychosis, and confusion. Dr. Martin evaluated the patient, ordered a AGB, read the results, then determined that the patient is in respiratory failure. Dr. Martin worked up the critical ill patient and carried out ventilator management. The total time spent on critical care service is 35 minutes. What CPT should be used for the critical care services provided to Mrs. Adams in the outpatient clinic? You have 2.5 minutes. Good luck, guys.
And yes, that's done. Thank you, Miss Karen, for reading the fourth scenario for us. And you guys are picking the pace. Great momentum. So the correct answer for this scenario, before that, let me highlight the keywords. 68-year-old patient brought to ED, orders an ABG. Patient is in respiratory failure. Dr. Martin workup for critically ill patient, carries out a ventilator management. And what's the total critical time here? It's 35 minutes. So coders, before solving the scenario. So thank you, Ms. Karen, once again. And so before solving the scenario, coders, is there a medically appropriate history or exam done? Yes. What's the location of the visit? It's an emergency department. Is this a new patient or established patient, coders? So that is not going to affect our code selection here. It's not going to, yes, it doesn't matter. It is not going to affect the code selection in our scenario. That's why I waited for your answers. So what's the total time of the visit? It's 35 minutes of critical care services which has been given. So when total time is being documented, we are going to solve them using total time. We are not going to use an MDM at the moment. So we are going to solve them. So let's look option A and option D, which is going for an emergency department E&M services. And we are having a guideline here which says that to report the critical care services provided in an outpatient setting, emergency department or office for the neonates and the pediatric patients through 71 months of age, see the critical care codes 99291, 99292. So we also have critical care service which has been provided in the emergency department in our scenario. So that would eliminate option A and option D, because we are going to code for critical care services here. We are not going to code from the emergency department. So option A and D is incorrect. And let's look at option B and C. For that, as I said, I'm going to use my critical care table because that is easy one for me. So what's the total critical care services provided here? It's 35 minutes, and where is 35 minutes falling in this table? So 30 to 74 minutes if critical care services has been given. Our ENM code, our critical care ENM code is going to be 99291. So that means option C is incorrect, and correct answer is going to be option B, 99291. Yes. Yes, how are you all feeling, coders? Let me know in the chat. How are you all feeling? I know you guys are doing good with the scenarios. How are you feeling? It's great, good. I can see the confidence is increasing in you all. Yes, more confident. That's the spirit. So let's move on to the next critical care scenario. And this time Sandra is going to come to the floor and read the scenario for us.
A patient with a history of chronic obstructive pulmonary disease, COPD, presents to the emergency department with severe shortness of breath, chest pain, and difficulty speaking. Endotracheal intubation is carried out, and the critical ill patient was placed on a mechanical ventilation. The ED physician evaluates the patient and makes changes to the ventilator settings as needed. The patient was admitted into the hospital after stabilization. Total critical care time, 90 minutes. What CPT code should be assigned for the ED physician's visit? Sorry, I should have read this first, but A, 99291, modifier 25. 99292 31500. B 99291 99292. C 99291 modifier 25 99292 99285. D 99291 modifier 25 99292 99223 and 31500. Coders, your time begins now.
And that is time once again. Let me look into the chat and let me look how are we all doing. Okay, I see some mixed answer for this scenario. So let's solve this one together. Thank you, Miss Sandra, for reading scenario number 5 for us. And what are we having here, Codus? We are having a patient with COPD who's presenting to the emergency department with shortness of breath, chest pain, and difficulty in speaking. An endotracheal anesthesia, endotracheal incubation has been given. Patient has been placed in mechanical ventilation. and the patient was admitted to hospital after stabilization. Total critical care time given is 90 minutes. What CPT should be assigned for the ED's physician's visit? So, Chorus, let us answer these questions first. Is there a medically appropriate history or examination performed for this scenario? So, the answer is going to be yes. What is the location of the visit? It's an emergency department visit, and we are coding for the services provided by the emergency department physician. The type of the visit is not important here. Total time of the visit, and that is going to be 90 minutes. So we are not going to use the MDM table here. And we are having a guideline to refer here, Chorus. So it states for reporting by professional, the following services are included in critical care when performed during critical period by the physician providing critical care, the interpretation of the cardiac output measurement, chest x-rays, pulse oximetry, blood gases, and collection and interpretation of physiologic data, gastric intubation, temporary cutaneous pacing, ventilatory management, and vascular access procedures. All the any services performed that are not included in this listing should be reported separately, and facility may report the above services separately. So, code does that means that any services which has not mentioned above in these paragraph, which has been provided during a critical care service, can be coded separately. So what do we have here in our scenario? We have ventilator management. Yes, that is included. And how about the intubation? How about endotracheal intubation? Is endotracheal intubation mentioned in this chorus? It's not included. So can we code them separately? Yes, we can code them separately. So that is one guideline which we are going to refer here. So option B is incorrect because that's only coding for a critical care service. It's only coding for E&M services. So option B is incorrect straight away. And next, again, we are going to review another guideline. And I would say option C is also incorrect because that is also coding for an emergency visit and a critical care services. Now, this guideline states that for critical care service provided by in the emergency department, see the critical care guidelines 99291, 99292. The critical care and emergency department services may both be reported on the same day when after completion of emergency department service, the condition of the patient changes and critical care services are provided. So coders, your question is the patient's condition stabilized or worsened after admission to the emergency department after giving the critical services? The patient's condition stabilized and patient was moved to inpatient admission. Patient was moved to the hospital. He was admitted to the hospital after stabilization. So these guidelines states that we can code the critical care service as well as emergency services when the patient has been admitted or patient has been reported to the emergency department in a critical condition, and doctor provides emergency department services, and then the patient stabilizes, and later his condition worsens and doctor has to give the critical services after that. So in those scenarios we can code the critical care and emergency department services together. So in our scenario, as I said, patient was stable. Exactly, the patient was stable and admitted. So we don't have to code emergency department along with the critical care services in this scenario. So option C is incorrect because of that. And option D is coding for an critical care service 99291 and 99292 along with an inpatient hospital admission observation code, which is 99223. So we are coding for ED physician services. We are not coding for inpatient hospital services here. So it's very important to read the last portion of your question. That will give us clear idea of what are we coding for. So it was what CPT code should be assigned for ED physician's visit. So we are coding for an ED physician visit, and he doesn't need to be coded for an inpatient E&M code. So option D is incorrect, and the correct answer is going to be option A, 99291, 99292, and 31500. So I would pull out my critical care table, and we can see total 90 minutes of services were given. So that's fall over here between 75 to 104 minutes. And my critical care codes are 99291 and 99292 times 1. And we also code for the intubation. Yes, we also code for endotracheal intubation, which has been provided. So these are our codes, and the correct answer is going to be option A. So coders, how are you feeling after that scenario? Does the explanation help? Let us know in the chat. So in the meantime, let's move on to the next critical care scenario. So once again, I would invite Miss Sandra to read the sixth scenario for us.
Hello, coders. Let's look at A being 99291, modifier 25, 90935, B 99291, C 99291, modifier 25, 99292, 90935, D 99291, modifier 25, 99285, 90935. A 68-year-old patient with a history of hypertension and diabetes presents to the ER with shortness of breath, chest pain, and confusion. Laboratory studies reveal elevated blood urea, nitrogen, BUN, and creatinine levels, and the patient is diagnosed with acute renal failure. The critically ill patient is placed on continuous renal replacement therapy, CRRT, and the physician evaluates the patient and adjusts the CRRT settings once during the encounter. She spends a total time of 75 minutes with the critically ill patient. What CPT code should be assigned for the critical care physician's visit? Coders, your time begins now.
So, coders, how are you all doing? You all are now starting to nail the critical care codes as well, critical care services as well. So, excellent responses in the chat. Way to go. So, let's highlight the keywords here. 68-year-old patient presents to the emergency department. Patient has been diagnosed with acute renal failure. And what has been given to the patient? Patient has been given with a continuous renal replacement therapy, which is CRRT. And total time of 75 minutes has been spent with critically ill patients. So total critical care services provided is 75 minutes. And these are our CPT codes. And again, the question, what are we coding for? We are coding for the critical care physician's visit or the services. And what do we have here? We have a 75 minutes of critical service provided and CRRT, which is a continuous renal replacement therapy, is also provided. So, coders, is CRRT included in critical care services? Are these services included in critical care services? Do we have to code them separately? Yes, they are not included in critical care services, so we are going to code them separately. And this is our critical care code table. And let's see, it's total of 75 minutes of critical care service provided. So it falls between 75 to 104 minutes, and our critical care E&M code should be 99291 and 99292 times 1. And yes, option A is incorrect because we have to go for 99291 and additional 30 minutes, which is 99292. Option A is missing that. Option B is also incorrect. Option D is also incorrect because they are also not coding for proper critical care e-service codes. And option C is the correct answer, which is 99291, 99292, and 90935, which is for CRRT therapy. So correct answer would be option C. So yes, you all are doing good. You are good with critical care coding, and I believe that's time to say goodbye to the critical care service section and move on to the next section, which is going to be medical team conference. Yes. So thank you, Miss Sandra, for reading that scenario for us. Reading the scenario number, I believe it was 7 or 6. Yes, it was 6. So let's move on to the next section, which is medical team conferences. And yes, so the case management is a process in which the physician or another qualified healthcare professional is responsible for direct care of patient and additionally for coordinating, managing access to initiating and supervising other healthcare service needed by the patient. So we have three codes here. We have three set of three codes, which is 99366, 99367, and 99368. So these are the guidelines for medical team conference. When a direct face-to-face patient and family team conference services are being given, we have to code for 99366. Without face-to-face or patient or family involvement not present, we have to code 99367 and 99368. Must have three minimum QHP, which is qualified healthcare professional from three different specialties or disciplines, must provide direct care to the patient, must have provided a face-to-face evaluation and treatment to the patient within last 60 days. The team conferences are time-based and begins at the start of the review of the patients and ends at the conclusion of the review. Time reported for medical team conferences may not be used in determination of time for care plan oversight, prolonged services, and psychotherapy, or any E&M service. So these are some of the guidelines for medical team conference. As I said, there are three sets of code. There are a set of three codes here. 99366, which is for a medical team discussion, in which a medical team will discuss the treatment plans in a meeting with the patient who requires attention from more than one medical specialty. And 99367, the physician will join the medical team in a meeting to discuss the treatment plan for the patient who requires attention from more than one medical specialty. And in 99368, a non physician or qualified healthcare professional joins the medical team in a meeting to discuss the treatment plan for a patient who requires attention from more than one medical specialty. So, with that, let's move on to the first scenario on medical team conferences. And this time, I would invite Miss Tanya to come on the floor and read the scenario for us.
Thank you, Mr. Sandeep. Good evening, coders. What CPT code should be used for Dr. Patap's participation in the medical team conference? Option A 99366, B 99367, C 99358, D 99215. A 50-year-old patient, Miss Davis, is receiving treatment for stage 3 breast cancer. Dr. Patel, the patient oncologist, organizes a 45-minute medical team conference with radiologist, surgeon, and RN to discuss Miss Davis' progress, review her imaging studies, and develop a comprehensive treatment plan that includes surgery, chemotherapy, and radiation therapy. The patient is not present at the conference. You have 2 minutes to solve this question.
So that's time coders. Any last entries? I'll give you 5 more seconds. Any last entries for this scenario? Okay, so thank you, Miss Tanya, for reading scenario number 7 for us. And let's highlight the keywords coders. It's a 55-year-old patient, Miss Davis, receiving treatment for stage 3 breast cancer. Dr. Patel, the patient's oncologist, 45 minutes medical team conference with the radiologist, surgeon, and RN. So there are three qualified healthcare professionals over here. The patient is not present. Whom are we coding for? We are coding for Dr. Patel's participation in medical team conference. So coders, remember Dr. Patel is a physician and the patient is not present in this scenario as well. And the correct answer is going to be yes, the correct answer is going to be option B, 99367. And again, as I said, look into the last portion of your question. Whom are we coding for? What are we coding for? We are coding for Dr. Patel's participation in medical team conferences. And option, yes, option D and C is coding for option C is coding for 99358, which is a prolonged evaluation and management service code. And option D is coding for 99215, which is an office or other outpatient services. And in our scenario, we are not coding for neither of them. We are coding for a medical team conference. Yes, we are coding for Dr. Patel's participation in a medical team conference. So option C and D both are incorrect. And now let's look option A and B. So total of a 45 minutes of medical team conference participation was there. A total time was 45 minutes. And let me look what option A is coding for, which is 99366. And coders, my question: why is option A incorrect? Why have you picked for all those who picked option B? Why is option A incorrect? Because we are going to have a moment here. Mhm. Okay, I can see great answers in the chat. So, coders, again, I asked you this question: whom are we coding for? We are coding for Dr. Patel, and Dr. Patel is a physician, right? And 99366 is coding for a medical team conference with interdisciplinary team of healthcare professionals face to face with patient and or family. My second question: was the patient present or the family present for the medical team conference? No, it was clearly documented that the patient is not present in this medical team conference and or participated by a non-physician qualified healthcare professional. So it's not a QHP, it's a non-physician, it's not a non-physician QHP who participated. It's a physician who participated in this medical conference as well. So the option A is incorrect in that 2 points. Patient was not present, patient of the family was not present. Second, it was it was a medical team conference with Dr. Patel participation in it, who's a physician. So with that, option A is incorrect and option B is the correct answer, 99367, which is coding for a medical team conference with interdisciplinary team of healthcare professional, patients, and or family not present. That's a tick mark. 30 minutes or more. Participation by physician. So does that make sense, coders? Exactly. I can see your answers in the chat. The way you have explained why you picked option B. Amazing, Goddess. So the correct answer is option B, 99367. So how are you feeling about medical team conferences, coders? Let me know. How are you feeling about medical team conference coding? Okay, so everyone is feeling good, great, and I know that you all are going to do good on that particular section. So we are moving forward to medical care plan oversight, and the guideline. Let's review the guideline for medical care plan oversight. So these are the guidelines. These codes are reported separately from the codes for office or outpatient hospital, home or residence, nursing care facility, or non-physician face-to-face services. Only one individual may report the care plan oversight services. The complexity and time of the care plan oversight services provided within 30-day period determine the code selection should not be reported for supervision of patients in nursing care facility or home health agencies unless require a recurrent supervision therapy. So now let's move on to the next scenario. And yes, this is scenario number 8. And I think once again Miss Dania is going to come and read the scenario for us.
Hi everyone. What CPT code should be used for Dr. Kim's care plan? Oversight service for Mr. Green. A 99375, B 99378, C 99380, D 99367. A 70-year-old patient at the Sunshine Farm Nursing Facility, Mr. Green has multiple chronic conditions, including congestive heart failure, hypertension, and type 2 diabetes. He requires ongoing care coordination and oversight by his primary care physician, Dr. Kim. Over the past month, has spent a total of 35 minutes reviewing Mr. Green's medical records, adjusted his medications, and communicated with other healthcare providers involved in his care, all outside of direct patient contact. 2 minutes to solve this question.
And that's time, callers. And thank you once again, Miss Zenia, for reading scenario 8 for us. So, yes, let's solve this one. The keywords here: 70-year-old patient, nursing facility, requires ongoing care, coordination, oversight by his primary physician. And what's the total time? It's a total time of service provided is 35 minutes over the past month, and direct patient contact was involved. And whom are we coding for? We are coding for Dr. Kim's care plan oversight services, and these are our codes. So let's quickly look into the codes which we are having: 99375, which is for a supervision of patient under care for home health agency 30 minutes or more. And this is incorrect because it's a wrong location. It is coding for a supervision of patient under care for home health agency. We have oversight services which is provided for a patient in a nursing facility. So option A is incorrect, and option B is coding for supervision of a hospice patient 30 minutes or more. Once again, it's a wrong patient. We are coding in 99378. We have nursing facility oversight care services which was provided, and option B is also incorrect. Option D is coding for 99367, which is for a medical team conference with an interdisciplinary team of healthcare professionals. So it's not a medical team conference in this scenario as well. So option D is also incorrect, and the correct answer would be option C, 99380, which is for a supervision of nursing facility patient 30 or more minutes. Yes, so we have seen it's a oversight services provider for nursing facility patient. So that's how I picked option C as correct answer. So that was a pretty straightforward scenario. Still good work from you all coders in the chat. So let's move on from oversight services, and let's see what are we having next. Yes, so we are going to review preventive medicine. Yes, we are going to review the preventive medicine counseling up next, and this is also an interesting section, and we have few guidelines here also. So these are the codes: preventive medicine services. The following codes are used to report the preventive medicine evaluation and management of infants, age, children's, adolescent, and adults. So the extent and focus of these services will largely depend upon the age of the patient. So age is an important factor while selecting the preventive medicine services. If any abnormality is encountered or a pre-existing problem is addressed with the preventive medicine evaluation and management, problem or the abnormality require an additional workup, then appropriate office or outpatient codes should also be reported with modified 25 along with appropriate preventive medicine services. So while during a preventive medicine visit or preventive visit, any problems has been addressed and has been evaluated along with additional workup, we can append the service or the outpatient service codes along with the preventive service medicine service CPTs. So next guideline, refer to the code 99401, 99402, 99403, 99404, 99411, and 99412 for reporting those counseling and anticipatory guidance or risk factor reduction interventions that are provided at an encounter separate from preventive medicine examination. The next guideline states a vaccine or toxoid products immunization administration ancillary studies are reported separately. So those are guideline on preventive medicine services. So let's move on And let's look into the first scenario under primitive medicine. So I would invite Miss Stephanie once again to read the first scenario for us under primitive medicine.
Thank you, Mr. Sandeep. Awesome. What CPT code should be used for Dr. Anderson's preventative medicine services provided to Ms. Clark? A 30 A 99385, B 99395, C 99396, D 99401. A 30-year-old patient, Ms. Clark, visits her primary care physician, Dr. Anderson, for an annual preventative medicine evaluation and management visit. Dr. Anderson performs a comprehensive age appropriate history and examination, as well as counseling and risk factor reduction interventions. No abnormal findings are discovered during the examination. What CPT code should be used for Dr. Anderson Preventative Medicine Services provided to Ms. Clark? And your time begins now. I wish you well.
So another scenario and another phenomenal response from you all coders. So thank you, Miss Stephanie, once again coming up for reading the scenario for us. And let's highlight keywords here. 30-year-old patient visits her primary care physician. Annual preventive medicine. No abnormal findings are discovered during the examination. And we are calling for Dr. Anderson's preventive medicine services to Miss Clark. And coders, so let's do some inventory here. Let's do some inventory. And what are we coding here? We are coding for preventive medicine services. And as I said in the beginning in the guideline, we can code an evaluation and management visit as well, along with the preventive medicine services if there was any problem addressed and that was managed, or any management was given towards that particular problem. So was there any problem in our scenario coders during this preventive medicine? Was there any abnormalities or any issues addressed? No. So it was clearly mentioned that no abnormal findings was observed during the preventive medicine visit. So we are not going to bill and or we are not going to code an office visit codes along with the preventive medicine services here. And as I said, let's do some inventory. So this is an annual preventive visit, and it's very important to know the age of the patient while going for annual preventive visit. So age of our patient in this scenario is going to be 30 year. Next important thing is to know whether it's an established or a new patient. So this is an established patient or reevaluation of preventive services here. So again, is there any abnormality detected or any treatment given towards that? No, no abnormalities was observed or detected. Now coming back to our options, let's quickly look what 99401 is coding for. That's for a preventive medicine counseling and or risk factor reduction intervention provided to an individual. Separate procedure approximately 15 minutes. Now this is for a preventive medicine counseling, and we had a preventive medicine visit. Actually, this is an annual preventive visit, so this is not coding for what our scenario requires or demands. So option D is incorrect, and option, yes, let's look what option A is coding for. 99385, this is for an initial comprehensive preventive medicine visit and age category between 18 to 39. So we already said, or we already observed, that this is an established patient visit and not a new patient visit. So option A is also incorrect. 99385 is also incorrect, and remaining two options are 99395 and 99356. Yes. So 99395, sorry, 99396 is coding for a periodic comprehensive preventive reevaluation and management for age category between 40 to 64 years, and the patient, as you all said, yes, it's too young. So option C is also incorrect, and the correct answer is option B, that is a periodic comprehensive preventive medicine 18 to 39 years old. So that's why I said while coding the preventive medicine, age is important, whether it's a new or established patient is also important. So these are small things, but you have to be forensic while coding these service ENM codes, because if you get anything wrong, they are going to give a wrong results for you all. So option B, 99395, is the correct answer. And yes, we are moving on to the next scenario, and I think it's Miss Sandra who's coming to read, and this will be scenario number 10 and the last scenario for the day, coder. So all the best, you are rocking it, and thank you, Miss Sandra. Please.
Thank you, Mr. Sandeep. Hello, coders. Our, I'm sorry. What CPT code should be used for Dr. Roberts' preventative medicine individual counseling services provided to Mr. Thompson? A. 99401, B. 99402, C. 99403, D. 99405. A 45-year-old patient, Mr. Thompson, visits his primary care physician, Dr. Roberts, for individual counseling on preventative medicine measures, including smoking cessation, weight management, and stress reduction. Dr. Roberts spends a total of 30 minutes discussing strategies and techniques with Mr. Thompson to help him adopt healthier lifestyle habits. You have 2.5 minutes for this challenge.
And that's time. And thank you, Miss Sandra, for reading the final scenario for us and coders. Yes, so this was pretty straightforward scenario, and yes, that's a good way to end the scenario. The keywords here is a 45-year-old patient, primary care physician, individual counseling on preventive medicine measures, smoking cessation, weight management, and stress reduction. A total of 30 minutes preventive medicine, individual counseling services provided to Mr. Thompson. So we are coding for a preventive medicine individual counseling services, and we do have guidelines here. We do have guidelines. Yes, so we are having guidelines which states that these codes are reported counseling, risk factor reduction, and behavior change intervention. These codes are used to report the services provided face to face by a physician or qualified healthcare professional for the purpose of promoting health and preventing illness or injury. They are distinct from an evaluation and management services that may reported separately with a 25 modifier. So that's a very good point to remember. Risk factor reduction services are used for persons without specific illness for which counseling might otherwise be required. may be used as a part of treatment. The preventive medicine counseling and risk factor reduction intervention will vary with age and should address issues such as family problems, diet and exercise, substance use, sexual practices, injury prevention, dental health, and diagnostic and laboratory test results available at the time of encounter. So, given that, the correct answer is going to be option B99402, because the total time of counseling spent here is 30 minutes, and option A, C, and D is coding for incorrect times. You have 99403 coding for primitive medicine counseling given for approximately like 45 minutes, 99401 for 15 minutes, and 99402 is the correct answer here. So how are you all feeling, coders? How are you all feeling after the first advanced E&M study sessions? Yeah, so in the first week, we have reviewed home visits, yes, critical care services, medical team conferences, medical care oversight, and preventive medicine counseling. We have covered all those sections and the guidelines over there. So this was the first week, and it was a little bit straightforward question. So I will upping the challenge a little bit for the next week, and we are going to have a great class next week. So evaluation and management is not going to be a topic for AMCI students. We are going to nail that section. So, Goddess, thank you for joining us for the week one of Advanced E&M Group Studies. Thank you, team, for assisting me and assisting the students. So, everyone, every chorus, see you all next Tuesday with more challenging scenarios. So, till then, stay safe and keep coding. See you all next Tuesday. Thank you, coders.
Thanks for tuning in, and until next time, happy coding!